calcification isn't quite as dynamic as I thought it was going to be relative to the puff that he had. And it does look like it's most likely associated with that deep flexor tendon. I don't think it was a suspensory at all. But
see, our first thing we talked about was sesamoiditis, wasn't it?
Yeah.
Say that again?
Sesamoiditis.
The first thing that we thought about when we first looked at him was sesamoiditis, you know. That was our first,
I remember that.
First diagnosis on him, you know. Was
Can we turn the light on?
But you can really see it on this view.
That help.
You guys want to come up?
Yeah.
I'm going to reset this. This is the view that we took across the body. And as you look at it, you can actually see that calcification coming up, and it's more to the back side. But you can see the strip of calcium right there.
Is that into the tendon
That's
itself?
in the tendon
It's
itself.
climbing up the tendon.
Yeah.
How about that?
So what apparently has happened is he had some sort of tear that, interestingly, healed with calcium, is actually deposited into the region itself.
So I'm sorry, I was distracted.
All
with
this
his
white
headbutt.
right in this region. Okay?
So what's the calcification?
That's what it is. The calcification most likely in the tendon structure itself.
Is that stuff jutting out?
No, that's normal
normal.
bone. It's this white streak that's
Oh.
coming
Can you
up.
go back to that other picture?
Yes. We're going to, I'm just going to go through the views that we took. This view is just the front to back view. And all it does is basically give us an idea of how the fetlock joint itself looks behind. You know, this is normal, this is where the growth plate was, where the sesamoids are, and the sesamoids appear to be in good position and normal in every respect as far as this particular view is concerned. And then we go to this next view, and this view is shooting from this direction laterally, and you can just start to pick up the calcium in this region, okay? You can't see it as good because it's the medial sesamoid. But as you look at these sesamoid bones, the trabecular pattern of the sesamoid is good. There's not any vascular, changes or anything to suggest
any
enlarged
fracture
vascular
lines
or any fracture lines. I mean, I think this is just part of the trabecular pattern. I don't think there's a fracture there at all. And then we look at this next one, and I could probably get us a little bit better view, because basically it's not a straight on, it's oblique slightly, but that's where this calcium is. It's coming off of that sesamoid bone, okay?
Is that doesn't seem like a lot to me, but I'm obviously not a trained.
Honestly, it's not. The only problem is its relative location in the tendon structure itself. It does create a relative inelasticity, which means that it's not as supple or as forgiving in that region. Okay? And my question to Nancy was, how does this look relative to
This
before?
is considerably better to me
That's
than
what
when
I
he
thought.
left.
And that's what Nancy said. It's actually gone
This is
down.
considerably better. When he left here, he had a lot of soft tissue. He actually had more to the medial, but he had soft tissue on the lateral as well.
Okay.
And he didn't have near the strength in that fetlock joint. It was much more flexed backwards.
Which probably is the reason why the veterinarian that you talked to up north suggested going in surgically and cutting that annular ligament. But I think it's probably because the level of swelling was so dramatic that chances are it looked as if that would have given him some relative relief. What we're seeing here, I don't think that annular ligament transection would actually make a whole lot of difference. So I'm of the opinion that the way he was shod and the way this is reducing in size, that is probably going to help decrease this significantly. And it's all soft tissue. It doesn't look like there's any fluid or anything. There's nothing that I think you can tap and drain or do anything of that nature.
So would you slightly wedge him and put a bar shoe on him?
Yep.
And rocker the toe and try to immobilize the knee for the flexation?
That's correct. Create a better breakover and minimize movement in that area in particular. Now the interesting part is that when you do palpate this horse, he does have some pretty significant sensitivity along that scar. And I can walk up there and do that, but he's gonna chew on somebody because I've already pushed all his little buttons. And he does have some sensitivity through his shoulders. And so it does make you wonder, particularly when you get this lined out, if we aren't going to find a dynamic where we're doing this, okay? And that's probably why the medial sesamoid is having some issues, and that deep flexor tendon is an issue. Whether or not these were related is anybody's guess. I think this created something that may have caused him some problems. is I'm going to touch him behind, and you palpate the scar. He does have a level of sensitivity in it, right in here. And I think it's actually creating a restriction of movement. Now, from where it's located, it can probably, particularly in this area, you can inject that scar and soften it up, kind of like they do in humans, and see if you might not get some relative relief from that area. It's old, but it could be that it'll help him. Just because you can see where we have that.
If you had to put a pattern together, looking at this horse, and then me knowing so much about his history for a pretty good while, this horse was compensating off of that scar, off of that the entire right quarter, and he has taken like an early morning dew slide and torn.
Yes.
Now that you're now that you're starting to be able to put a whole scenario together,
right?
He has had to have slid,
in order to cause that.
Torn that. When he tore it, he tore the periosteum loose from the sesamoid bone, which would be shin buck.
Right.
Calcium leaked out and followed the scar tissue up.
Chances are, yeah, exactly. It's inevitable that we probably had what would have been considered kind of an avulsion fracture. Though we don't see an absolute piece off of the top of that sesamoid, what we do have is an attachment pull, and I think because of the trauma to it, the way his body chose to heal it was to lay down calcium, rather than if it were like a mid-body tendon injury. See what I'm saying?
For him to lay down calcium, the tendon sheath has a welding effect to the sesamoid.
Yes, it
Agreed?
does.
All right. So for that to happen, for the combination that it had to have torn the periopal loose.
Yes,
periosteum.
Periosteum.
It tore the periosteum loose from the sesamoid
right.
bone, which is the same as shin bucked in a race coat.
True, and so what's happening is the body is healing a soft tissue and acting as if it's bone, but not soft tissue. See what I'm saying? Not like if it were if you had a bow in front and say it was a mid-body, tendon sheath bow or superficial flexor tendon or deep flexor. Those dynamics are going to be such that you're going to see blood in the region, you're going to see tearing of that pattern and so forth, but you technically never see it lay down calcium. It's normally when it's associated with a bony attachment that you actually see that area, and it just has to do with the healing process of the body and the way it chooses to heal. What turns on and turns off in these areas.